Welcome back to Neurology 101 here on the ProPA podcast. I'm Dr. G, and today we're continuing our vascular neurology series by diving into one of the most terrifying types of hemorrhagic strokes, the subarachnoid hemorrhage, or SAH for short. This isn't just a headache, it's a thunderclap, and one you'll never forget. Let's dive a little deeper. Did you know that up to 50% of patients with SAH die within the first 30 days, and a large percentage never make it to the hospital? Early recognition and rapid action can mean the difference between life and death. Let's look at the kinder patho. What is a subarachnoid hemorrhage? Well, a subarachnoid hemorrhage is bleeding into the space between the arachnoid and pia mater. That's the subarachnoid space. The most common non-traumatic cause is the rupture of a berry aneurysm, particularly at the arterial branch points of the circle of Willis. Other causes include trauma, which is the most common overall, AV malformations, and cerebral vasculitis or tumors, which is less common. The bleeding leads to irritation of the meninges, causing headache and nuchal rigidity, cerebral vasospasm, and increased intracranial pressure. So how do these patients typically present? Well, they get a sudden, severe headache, and they often describe it as the worst headache of my life. They can also have nausea and vomiting, nuchal rigidity due to the meningeal irritation. They can have photophobia, loss of consciousness, or altered mental status, and they may have focal neurologic deficits. A sentinel bleed is a warning leak days earlier. So how do we make the diagnosis? Well, we start with a non-contrast CT of the head. This is the first step, and it's highly sensitive within the first 6 hours. If a CT is negative and the suspicion remains, we can perform a lumbar puncture, and we're going to look for xanthochromia, or elevated opening pressure. A CT angiography is also used to identify aneurysms. If you need more look into different types of thunderclap headaches, take a look at our Thunderclap headache podcast episode. All right, now let's look at the management. So, neurosurgery and neuro ICU admission is key. We also want to control the blood pressure. We are aiming for a systolic blood pressure less than 160. We can use labetalol or nicardipine. We want to prevent vasospasm, so we also give nimodipine, a calcium channel blocker. We're going to monitor and treat the increased intracranial pressure by elevating the head of the bed and giving hypertonic saline solution. We also want to give seizure prophylaxis in select cases. Surgical clipping or endovascular coiling of the aneurysm can be done by neurosurgery. All right, book med versus street med. So the book med is going to say we have an SAH, which equals a thunderclap headache plus photophobia plus stick neck. We're going to get that CT, consider getting that LP, and consult neuro ICU. Street med, patient's going to say, Doc, I have the worst headache of my life. Your heart's going to drop. You grab a CT, prep for possible LP, and call neurostat. This one needs your full attention. All right, so some quick clinical pearls. A negative CT does not rule out SAH. If in doubt, LP it out. Xanthochromia equals yellow CSF from RBC breakdown. Nimodipine prevents vasospasms, a delayed but deadly complication. And we always want to ask about worst headache of life and pay attention to sudden onset. All right, let's do some practice questions. A 54-year-old woman presents with a sudden onset, severe headache, and nuchal rigidity. CT shows blood in the subarachnoid space. What medication should be started to prevent vasospasm? Is it A, labetalol, B, nimodipine, C, mannitol, or D, phenytoin? If you said B, nimodipine, you are correct. Remember, this is a calcium channel blocker and it is used specifically to prevent delayed cerebral ischemia from vasospasm. What's the most appropriate next step in a patient with sudden onset headache, normal neuro exam, and normal head CT performed 12 hours after symptom onset? Is it A, an MRI of the brain, B, a lumbar puncture, C, repeat the CT in 24 hours, or D, carotid ultrasound? I'll give you a few seconds. If you said B, lumbar puncture, you are correct. Sensitivity of a CT drops over time, so an LP is indicated when the CT is negative, but SAH is still suspected. Alright, so some final thoughts. SAH is a true neurologic emergency. When someone says, worst headache of my life, don't ignore it. Work them up. CT, LP, and a rapid neurosurgical evaluation can make all the difference. Next time, we'll shift gears into one final hemorrhage stroke type, a lateral medullary syndrome, also called Wallenberg syndrome. It's a brainstem stroke with a unique collection of signs worth knowing for both exams and clinical care. If you're loving the Neurosurgery 101 series, don't keep it to yourself. Share this episode with your classmates or give us a quick review. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.